Hello everyone and Happy New Year. My name is Candace McCary. I have been a physician assistant for the past 6.5 years, and I was asked to go ahead and do your lecture today on operating room technical skills. The operating room has been a passion of mine. I love surgery. I feel so honored to have had the opportunity to work with some amazing surgeons and patients. So let's go ahead and dive in here, and we'll go to our first slide here. Conflict of interest disclosures. I have none for this presentation. I have no paid sponsors. The videos and links that will be within this presentation, I am not affiliated with the creators or companies, nor do I endorse them, but I do put them in here just because they're fun to watch. They're educational, and I love the presenters' personalities. My professional experience as a PA, I graduated from Ch1 University in 2016, just like you guys will, not in 2016, but a little bit later, and with a Master's of Science in Physician Assistant Studies and a Master's in Public Health. And then a couple years ago, I went ahead and decided I wanted my doctorate in medical science, so I attended the University of Lynchburg in Virginia. So I completed that. I've worked in a lot of specialties over the last 6.5 years, just because doors opened and I decided to go for it. I started out in emergency medicine after graduating, worked in a level 1 trauma center in Santa Clara. You guys may even have rotations through them still. And then I also did per diem work in a small community hospital in Hayward called St. Rose. I did that per diem, and then a little bit more per diem in Santa Clara after working there for full-time for a while. And then I had the opportunity to work in medical, surgical, and cosmetic dermatology in Hercules with 4 dermatologists. And then I moved to another state and I worked at a university in student health and did primary care, which was so much fun. And then I also worked in bariatric surgery at UCSF in San Francisco. I was one of only 2 of us PAs at UCSF in general surgery. So that was very rewarding, worked with a lot of talented people. And most recently, I worked for a single surgeon practice. I was her only physician assistant, and it was in breast surgery oncology and gynecologic surgery. We brought on another surgeon, and then I went out on maternity leave, and our family actually decided to move out of state. So now I'm currently in Utah, and I'm joining a practice that a few family practice physicians and emergency room physicians, along with PAs and NPs, decided to start their own company. One side's a family practice, the other is urgent care. So I decided to join in and be part owner in that. So I will be starting that in the next month. So I'm very excited about it. Sad to be leaving surgery, so because it's been a big part of my career. But you will hear me throughout this presentation referring back to the two big specialties that I've worked in bariatric surgery and breast surgery. So I will go back and forth between my experience with both of those throughout this presentation. But both are a big joy and love of mine, and I love the patients. So you'll hear a lot about that. So I've had the opportunity to work in all of these specialties. It has made me the PA who I am today, and I am definitely better for it with my experience and how I care for my patients and the care I provide to them. Okay, so let's go ahead and move ahead here. So there are some surgical PA duties that you may see as a student. If you decide to go into surgery, these are some of the things that you will do. And these are some tasks and assignments that I had as I was a surgical PA. So pre-op planning, coordinating with anesthesia, and these are things that you do. It's different with other, you work with a lot of different people as you're trying to get your patient into the operating room, whether it be planning or a planned or unplanned procedure. You're going to be talking back with anesthesia and a lot of different other specialists, some other things that you will do as a surgical PA. You do a lot of pre-op evaluations. So when your patient is coming in for an appointment to get a surgical procedure done, you're going to evaluate them. You're going to order labs, studies, possible medications. You're going to order some specialty referrals in case they need clearance by a specialist. You're also going to do pre-op histories, physical exams. So this is when the day of surgery, you're going to be going in and seeing your patient before they're wheeled back to the operating room, or you're also going to be doing a pre-op possibly beforehand, like a week before, a couple of days before. But also you're going to see them before they're wheeled back into the operating room, and you're going to do a quick history, physical on them again. And we'll talk a little bit more about consultations you'll be doing, that as well as a student. I did a couple of consultations as a student in the emergency room during my general surgery rotation in regards to cases that were laparoscopic cholecystectomies, appendectomies. We had a couple of people who presented acutely for those items, and as a student, you'll be going in and seeing them in the ER, evaluating them. You'll also assist in the operating room, and sometimes this can usually be first assist, but if you are in a teaching hospital, the residents and fellows will come in and they need to learn, so you can help teach them if you've been there for a while, or they kind of have precedence at that point. So sometimes the resident or fellow will be the ones who are definitely first assisting. You may be second assisting in that case, just because they are a resident or a fellow. There's still hierarchy sometimes in surgery. But as a PA, as a student, you will learn how to do op notes. You will do those as a practicing PA. Admission orders, post-op floor orders. Sometimes the surgeon likes to do these instead of you, but you will get your chance to dip your toes in that. Rounding on patients. As a PA, I did this. As a student, you may be asked to round on patients. I did. It was treated like a residency. For me and my general surgery rotation, I rounded every morning on patients, midday, and then in the evening. Discharging patients, this depends. Some hospitals prefer the surgeon discharge their own patients. Otherwise, the PA discharges the surgical patients as well. So I would do that in the mornings at about 6:30 in the morning and go and discharge our patients if we kept them overnight. That was more in breast surgery oncology. I did that multiple times a week. In bariatric surgery, I did not do that. We had nurse practitioners inpatient who would discharge the patients. You will take call. If there's a couple of PAs, you guys can, share a call. But as a surgical PA, I took call. I would answer a patient's questions via phone, in my in-basket. If there was an emergency, I would, talk to the patient and then talk to my supervising physician. Breast surgery oncology was kind of 24-hour on call, but it was rare if something happened where we would have to go into the office. There is a chance you could do minor procedures as a surgical PA. So that can include anything from little biopsies, cyst removals, abscess, IND, draining of a cyst, also draining of seromas, hematomas, those types of things. You may have the opportunity to do research That's something where you can gather data as a surgical PA from your practice and do research on your own. That's really fun. If you're at teaching hospitals, they really encourage that. UCSF did. Um, as a surgical PA, you'll do a lot of follow-up appointments, so immediate post-op appointments. Patients can have a post-op a week from surgery, a month, 3 months, 6 months, 9 months, a year, and then long-term follow-up annually. So I did that with bariatric patients as well as breast surgery oncology patients. When I worked in bariatric surgery, I did a lot of pre-op education presentations. So patients would come in once a week, and we would have, before they had their visits with the surgeons, it would be a group that would come in, and I would do a full hour or more of a pre-op education PowerPoint presentation, because there's a lot of information and patient education for bariatric patients as well as breast surgery oncology patients. Also, as a surgical PA, you'll be doing a lot of wound care, a lot. So patients will come in, you'll be doing staple, suture removals, drain removals. This is something that you need to become comfortable with as a surgical PA, because you're constantly looking at surgical wounds and making sure that they're okay. So, and treating them, changing bandages, all those things. And then other surgical PA duties, anything within the scope of your supervising physician, as well as what they are comfortable with you doing. So, and here, I'd like to add a little plug-in about OTP and working as a surgical PA. It is a little different working environment in surgery. Most of the patients you see are your surgeon's patients. You are their assist. You are their first assist. Yes, you collaborate with them, but there is a sense of pride in being their PA, basically, if that makes sense. You're very proud to be their PA and represent them and work as this, functioning unit in the operating room to take care of your patients. So it's a little bit different, less per se autonomy than working in the emergency room where you feel like you're your own provider. Okay, so here are some surgical PA clinic duties. We're not going to go through all of them. This is just some of PA clinic duties. Some of them admin's kind of tied in here, and I have one slide for admin duties too, but I've tied them into these slides as well. So as surgical PA in clinic, we conduct pre-op evaluations, like I said, history and physicals, immediate post-op and long-term follow-up care, and we perform procedures like we talked about. We provide tons of patient education, counseling regarding surgical procedures, the risks, the benefits of each, wound care, surgical site management, and medication management. We also communicate with the patient and family members by phone, MyChart, like through Epic, things like that, to answer questions or clarification of post-op orders and wound care, and evaluate for problems that may come up along the road, because they do. But a lot of time is spent answering patient questions and family questions. We do provide surgery clinic phone coverage, prescription coverage. We answer pre and post-op, again, email, Apex, and basket questions, like I said. Place a lot of imaging orders, interpret them, call the patients, and let them know what those orders look like. So since I worked in breast surgery oncology, it was a lot of breast imaging, going over those results. We obtain surgical and blood transfusion consents for surgery. We also hold information clinics. And again, like I had said earlier in the previous slide, all the different visits that we can see, new patient exams, things like that, annual acute pre-op post-op visits. We also provide referrals to medical specialists, nutrition counseling for patients, PT, OT, and pain management. Some surgical patients, you see them, they're in and out, they have their surgery, and you may never see them again after their first, post-op. Others, though, you're constantly adjusting medications that they might be taking lifelong. You may be ordering their, imaging studies for the rest of their life, like in the case of breast cancer surgical patients, I would order their mammogram, their MRIs, ultrasounds, things like that annually or every 6 months, breast imaging. And then I would have to call them with the results, talk to them about it if they needed any further follow up. So, as a surgical PA, you'll interpret tests, imaging, pathology results. So, once their surgical path comes back, biopsy results, anything like that, you sit down with them and you go over that path report. And sometimes it can be pretty daunting and emotional if there's a result that is not an optimal result. But you go over that with them. You will again do a lot of wound care. You assess the site for infection, hematoma, seroma, wound dehiscence, and necrosis. And we'll go over some of those here in a little while. I'll show you a couple of pictures of patients that I've seen. You'll also, again, do drains, staples, and suturing sometimes, especially in the operating room, though. So you will be placing those, and you'll learn how to do that on your rotations. So be prepared. As a surgical PA, you want to try and get the patient's, their packet ready for chart review and make sure everything is together before they have their surgery. A lot of times you can have high-risk patients, especially in a teaching hospital like UCSF. So there's a lot of information that you have to continuously compile and review to determine that everything is complete, that the patient is ready for surgery, and it's going to be a safe environment for them. And during that time, the patient always wants to know, am I ready for surgery? So you're constantly informing them about their packet status and if they have any outstanding studies, if they still need to be cleared for surgery by certain specialists. And so you need to help them get those consultations and all those things done in order for them to be ready for surgery day. So next slide here. A little bit more duties. Again, we talked about all this, but there's more things: disability forms, family leave, home health, DME, prior auths, peer-to-peer reviews. A lot of times insurance can be a bear and you're trying to get things approved like surgery or imaging. And you have to pretty much fight for your patient in order to get these things done for them. So you're still doing path requests, specialty consultations, again, referrals. I did participate in weekly tumor board. We would present patients for review and go from there based on what are the next steps for treatment, if they need further surgery, what types of surgery, what type of surgical procedure, and next step referrals, oncology, medical oncology or radiation oncology, things like that. Sometimes, depending on your role, you can assist in formulating and implementing certain protocols to improve efficiency in the clinic, like quality improvement projects. You can also help collaborate with other fellows, residents, faculty, physicians with research studies. You can gather data for those. You can also revise some educational and clinical care, written materials. I did that with another PA. We worked on a lot of the diet booklets and diet plans and other educational materials for our bariatric patients. I also did this for our breast surgery patients for pre-op and post-op instructional care. And here are some more admin duties. I won't go into depth with these really quickly, but you can help with marketing for your practice, with social media. A couple of PAs I know, they do a lot of Instagram if they're in plastics, so it's a big deal. So they will do a lot of Instagram posts of videos with procedures that they've done, cosmetic things like that, and surgeries. So it helps bring up your patient volume. You can help with, again, certificates, specialized certifications for your clinic. Some of these are required for you to be able to practice bariatric surgery. you have to be a specialized certified clinic in order to do bariatric surgery. There's an organization that is kind of the governing body over a surgery center becoming a certified bariatric surgery center or an MBS AQIP surgical center. So those are some things that you do as a PA. You can also, again, deliver educational seminars, monthly support group meetings for your patients, and conduct quarterly administrative meetings, and talk about upcoming goals and quality improvement. So moving on here, let's go over some common general surgery procedures. So here's some of the fun stuff. So you will see as a student laparoscopic cholecystectomies, so acute choles, hernia repairs, and the most common are ventral and inguinal hernias. There's laparoscopic Nissen fundoplication. So this is something you will see in general surgery. Some of the surgeons are moving on more towards the robot, and we'll talk a little bit more about that. For these, there's foregut surgeries. So Nissen fundoplication, if you don't already know what that is, or Nissen fundoplication, it's for patients who have chronic GERD. And of course, if you do not take care of a particular patient with GERD, they have the potential to develop Barrett's esophagus. And we don't want them getting that. So what we do is we go in surgically and we take their stomach and we wrap around the fundus, around the top of their lower esophageal sphincter. So that way it kind of constricts and helps reinforce that lower esophageal sphincter muscle, and it prevents the reflux from going back up. So that's a simplified version. You'll also see appendectomies, colon resections, hemorrhoidectomies, cyst and lipoma removals, breast biopsies, lumpectomies, mastectomies, along with sentinel node biopsies and axillary dissections. You could see and help out with skin cancer excisions. So sometimes there's skin cancer that is in a small area or a large area that needs to be removed, but it could be in a very difficult, tricky spot. There might be some structures there that are just best done not in a derm clinic setting, but in a surgical setting. So you may see some of those. I only saw one in general surgery. You will be able to help out with wound debridement, abscess and IND, especially deep space abscesses. And again, you have to be really careful about those being near vital structures, like vasculature or nerves, things like that. So let's go on to the next one here. Some on-call and urgent cases that may pop up, again, acute cholecystitis, appendicitis, hip fractures, open reduction, internal fixation fractures. I saw a few of those from car accidents that were, that in that case, there's a lot of ortho equipment, tools, things like that to stabilize a joint. It's pretty amazing to be in the operating room with those with ortho. Ectopic pregnancies, you'll see ovarian torsion potentially, but that's rare. I never saw one of those. Ruptured ovarian cysts, tracheotomies, urgent cases, colon perforations, small bowel obstructions, again, internal hernias, which it's usually caused by adhesions, kind of like a small bowel obstruction with internal hernias. It's a type of hernia within the abdomen. It leaves a bowel or mesentery that can become caught and twisted, and so therefore it's called an internal hernia. So it can, the other things are strangulated and carcerated hernias, of course, like that. Deep space abscesses, like we just talked about. Post-op bleeding, hematomas that can occur, they can form post-operatively or due to trauma injuries, leaks from bariatric surgery, You can have ear, nose, and throat urgent cases, plastics, general surgery, other things like that can just pop up. So let's move on to the next slide here. So like I said, there are things in the pre-op visit that we order before the patient has surgery. This is kind of surgeon dependent and the type of procedure that the patient is having. So some labs that you may order are a CBC, CMP, lipid panel, hemoglobin A1C. You want to look at their clotting, so you're going to look at INR, PT, PTT, sometimes vitamin D, depending on the procedure. With bariatric patients or anytime you're going to be doing an abdominal procedure, foregut, things like that, you may order an H. pylori, stool antigen, or breath test. You may also order a TSH, PTH, and calcium. So these things we look at in a bariatric patient or any type of particular abdominal procedure. Potentially, if a patient is more at risk for gastric ulcers, we want to order these because we want to make sure that we eradicate any type of bacteria that can potentially cause gastric ulcers in a bariatric patient's stomach, because we're going to be making and shrinking their stomach size to about 2 to 2.5 ounces, about the size of like a hard-boiled egg. So we really don't want them to have the potential to develop an ulcer and possibly have a gastric rupture. So we want to get rid of that beforehand. So there's some imaging here that you may want to order depending on the procedure: chest x-ray, MRI, CT, some specialty tests, again, EKG, ultrasound, upper endoscopy. If it's going to be a foregut surgery, there are some specialty consults, surgical clearance. So some insurance companies want to see that a patient has been cleared by their primary care physician before they have surgery. Sometimes the patient needs to see an oncologist prior to, like a medical oncologist, prior to surgery, or radiation oncology, depending on the size of a tumor. If they need to start a medication prior to, like chemotherapy or radiation to shrink a tumor before surgery. Also hematology, cardiology, if the patient has a history of cardiac disease, or you just need cardiac clearance based on patient's age. Also pulmonology, etc. So anesthesia will also call the patient prior to surgery and talk to them and do a history. They usually don't do their physical until day of surgery when they come to their bedside right before taking them back to the operating room. But they will also give the patient special instructions. One thing that you really do want to inquire about in a pre-op visit with a patient is about their ETOH use, smoking cigarettes, if they use marijuana, or illegal substance use. And I forgot to mention vaping. Also anything with nicotine right in it. Some surgeons require a patient quit smoking prior to surgery and discontinue for a time after because of issues with wound healing. So there are a lot of studies that have come up that show the effects of smoking and its impairment on wound healing, especially if patients are using nicotine products. So we want the best outcome for a patient, and we want to avoid wound dehiscence or infection. So again, when I worked at UCSF, we wanted patients to quit smoking 3 months prior to surgery. Most surgeons are a month prior, but generally the case has been, we really want you to quit. Bariatric patients, we want them to quit indefinitely. We do not want them to smoke. Any patient, you don't want them to smoke. But it's extremely important that you really push that home to the patient, that this is going to really cause problems with wound healing. I've had a couple of patients where it just took forever for their surgical site to heal. Even though they said they quit, they really hadn't, and it really affected them, and they admitted later that they had continued smoking, and it was really hard to get their wounds to close. Okay, so next slide. So meds to discontinue prior to surgery. This again varies, but in the two specialties that I've practiced in, these were recommended. So we asked that a patient stop estrogen containing medications like hormone replacement therapy 6 to 8 weeks preoperatively. And then oral contraceptive pills, we asked them to discontinue at least 2 months prior to scheduled surgery date. So this kind of all depends on the provider. Some, again, are 6 to 8 weeks, some are 2 months. But we asked them to stop these just due to the risk of blood clots, DVTs, PEs. So it's very important that a patient adheres to this. Also, we have patients stop NSAIDs 10 to 12 days prior to surgery. This can vary. With bariatric patients, it was 7 days. Some surgeons prefer 7. In breast surgery oncology, where I worked, it was 10 to 12 days prior to surgery. So this includes ibuprofen, Aleve, aspirin, those types of things. Even turmeric, because that has kind of a non-steroidal anti-inflammatory effect. But with bariatric patients, we wanted them to discontinue these 1 month prior to surgery instead of just the 10 to 12 days. Sometimes though, 7 days was fine. It goes back and forth between the surgeon. However, with bariatric patients, NSAIDs are contraindicated for the life postoperatively. So just due to the risk of them potentially developing a gastric ulcer in their tiny gastric pouch and having a rupture, we just avoid NSAIDs completely for bariatric patients. Another thing that we have patients discontinue 5 to 7 days prior to surgery are blood thinners. So particular blood thinners, Coumadin, warfarin, again, Xarelto, those things, other names for them. You can always check with your outpatient pharmacy team. You can always check with the patient specialists who are prescribing those medications, see when they would like the patient to stop them, if there needs to be a heparin, Luvonox bridge for them. Depending on the procedure, we will prescribe heparin intraoperatively and during their hospital stay, depending on, again, the length or type, and then their risk factors. So just to avoid blood clots. And we'll talk a little bit more about some other things of how we prevent those with surgery. We also ask patients to stop fish oil prior to surgery. And the reason being, with fish oil, there's been some studies showing the possibility of thinning of the blood, but there isn't really concrete evidence that we've seen, but we're still very cautious, so we tell patients to stop that prior to surgery. Another one is stopping steroids. So I'm sure you've learned about this in class. Steroids can cause adrenal suppression, even if it's just a small dose, like 10 milligrams per day. Your cortisol level rises significantly in response to surgery. So taking steroids places the patient at risk, if not, they can't respond adequately due to this suppression, being on steroids constantly. So it can lead to possible hypotension, infections, delayed wound healing, all those things. So that's something you need to look into and see if the patient is doing that. Again, we talked about smoking cessation. This varies per surgeon. With bariatric surgery, it was 3 months prior to surgery. In breast surgery oncology, it was around a month. But every surgeon is different, and they will counsel their patient differently on that. So in the next video I'm going to share, we're going to talk about welcoming you into the operating room. We're going to show some videos. We're going to talk about certain medications, surgical attire, PA duties again, your responsibilities in the operating room, patient positioning, all the fun stuff. So that will be in the next video.